Excuse me. Good morning, everybody. This is one of my fun jobs is to introduce the sub-Is and let them give their talk to all the scholars on the other side of the Zoom. So we're going to start out with Alexander Agopian Mew, who's from Columbia, one undergrad. He's kind of ping-ponged across the country. He went to Berkeley undergrad, and he is now at Columbia University. Vagelos College of Physicians and Surgeons, and he was Phi Beta Kappa in college. He was an NIH T35 student at Columbia. He he contributed to 3 publications. And tell us one thing about you, Alex, that we don't know maybe, and I know you were a competitive swimmer at Cal, correct?
Yeah, I was on the Masters Cal team, and I would say one fun fact about me is the last thing that I did in the Bay Area was I swam from Alcatraz to the San Francisco shore.
Wow, that's
Yeah.
impressive. That's an impressive, that must be quite hard actually, right?
Yeah, I was told that I would have a moment of Zen where I could look out into the bay and see the views, but I just kept my head down, and before I knew it, I was at the shore. So I was kind of disappointed, actually.
Good for you. Fabulous. I once took a boat that direction. So without further ado, Alex, why don't you tell us what you're going to speak about?
Sure. So hello, everyone. My name is Alex Agopian, and I'm a visiting student from Columbia. And today I'm going to be talking to you about the research that I conducted under the co-mentorship of Dr. Guy McConn and Dr. Catherine Chabon. I have no conflicts of interest to disclose. And broadly speaking, I spent my research year investigating neural activity patterns during seizures from limbic structures in order to hopefully help further refine our understanding and mapping of focal seizure spread. Now, this is important from a surgical standpoint, since accurate localization of seizing tissue is crucial for the 20 to 30% of the 3 million Americans in the US with epilepsy who resort to surgery after multiple failed medication trials. Now, seizures are thought to represent areas of abnormally excitatory activity, excessive excitatory activity that results in a clinical state change. And there are 2 paradigms within which this abnormal activity is thought to arise. In one paradigm, supported by animal and human studies, seizures are thought to be the result of focal processes that result in 2 well-defined territories of contrasting ictal neural activity patterns, where one territory is thought to represent actively seizing tissue and is characterized by synchronous neural firing that's entrained to the local field potential. It's also been shown on a single unit level or on a neuronal level that there are extracellular action potential waveform changes that correspond to paroxysmal depolarizing shifts that have been seen in animal models of epilepsy that have been considered a cellular hallmark of actively seizing tissue. Now, the other territory in this paradigm is thought to represent tissue that is not actively seizing, but is instead responding physiologically to the feed-forward synaptic barrages from the ictal focus. However, an emerging theory is that seizures are the result of network processes, and the thinking behind that goes that, well, since the brain is inherently an anatomic functional network, seizures must also be a result of said network. And some of the evidence cited in favor of that include the fact that the electrographic signature of seizures on EEG appears to spread to areas centimeters apart almost instantaneously after seizure onset. And some groups have found that on a neuronal level, neurons increase their firing in areas not presumed to be seizing based on these canonical EEG traces, while neurons in areas that are presumed to be seizing actually decrease their firing. And so the implication there is then that it can't just be the areas with electrographic evidence of seizures that are involved in the process. But with that being said, most of the work for the focal natures of seizures has pretty much been established in neocortical data sets. So my study more specifically investigated if there are evidence of dual ictal territories in limbic structures as well. And to do this, I used combination depth electrodes with Bankman-Fried microwires in order to assess neural data in patients undergoing pre-surgical evaluation for refractory temporal lobe epilepsy. And the benefit of using these combination electrodes is that it allows me to assess a wide array of neuronal activity across the well-established limbic network. So in total, I had 52 electrodes from 19 patients, and I analyzed data from 34 seizures. And for this data, I segmented the data into specific frequency bands to get at different resolutions of neuronal activity, so to speak. So if we think about it as like magnifications on a microscope. At the lowest magnification, you have the low frequency rhythm in the 2 through 20 hertz, or the local field potential. And this represents the summated electrical activity of tissue immediately surrounding the electrode, as well as tissue far away from the electrode. And this is the band that epileptologists use to look for stereotype deflections in the signal that have been associated with seizures. And so for my study, I denoted whether or not each electrode was in seizing tissue based on an epileptologist's read of this band, and they will be noted as the epileptogenic zone, or EZ. Now, the next magnification up is facilitated in, or is in the 80 to 150 hertz frequency band, or the high gamma band, and this allows me to assess the aggregate activity of a local population of neurons around the electrode. So I can determine their firing through high gamma amplitude, where greater firing corresponds to greater amplitude, as well as their entrainment to the low frequency rhythm, as given by this phase locking value, or this PLV metric, where a value of 1 implies that the population is either always firing at the peak or at the trough, or at some specific phase of the low frequency potential. And I just want to take a moment to note here that this metric has been shown to be increased in areas that have been thought to be actively seizing, or in other words, there's synchronous population firing entrained to low frequency rhythm in areas with seizing tissue. Now, the next and final magnification up is facilitated by the use of these Bankman-Fried microwire electrodes, which now allows me to assess the activity of a handful of neurons within that population, so something like 1 to 10 neurons. And like I could with the population, I can measure their firing rate, as well as their entrainment to the low frequency potential using this Rayleigh-Z test statistic. But more importantly, I can assess their extracellular action potential waveforms to see if I can detect changes in that waveform that correspond to the paroxysmal depolarizing shifts, or that aforementioned cellular hallmark of seizing tissue. Now, in order to make sense of this high dimensional data set, I use principal component analysis to plot each electrodes in 2D PC space, where electrodes with similar activity patterns or similar electrical activity should congregate together. And I hypothesized that I'd really only have 2 groups of electrodes representing actively seizing tissue and not actively seizing tissue. And when I do this study, I find that a 2-cluster solution does best characterize the data in 2D PC space, since it optimizes the ratio of intercluster variance to intracluster variance as given by this Kolinsky-Haberras index, where greater index values implies that you have tight clusters that are well separated from each other. And interestingly, cluster 2 corresponded to almost all of the electrodes that were determined to be in seizing tissue based on an epileptologist's read of the low frequency potential. And the hippocampus is well represented in both clusters. So I think this suggests then that there are 2 states of activity when it comes to seizures and limbic structures as well. And no clear patterns emerge with further clustering of the data, such as with 3 clusters or anything beyond 4 to 7 clusters. So to draw an additional line of evidence that these clusters are tapping into something physiologically distinct, I analyze a 10-minute interictal sleep epoch for each electrode in the data set to quantify the amount of high frequency oscillations. And high frequency oscillations are these stereotype deflections in the raw signal that have peak power in the 80 to 500 hertz frequency band that are thought to be biomarkers of epileptic tissue. And I find that in the cluster associated with almost all of the electrodes within the epileptic zone, there's a greater amount of interictal HFOs compared to the other cluster. So to push this 2 brain state idea a little bit further, what I've done here is I've selected 2 electrodes that are recording from the same seizure in the same patient that ended up in different clusters despite nominally being in the same limbic network. And we can see here that the hippocampal electrode displays evidence of actively seizing tissue given its greater PLV values or phase locking values, whereas this mid-cingulate electrode doesn't seem to be changed much from its pre-onset baseline. And in fact, phase locking value is one of the best metrics at distinguishing between these 2 clusters, which recapitulates the findings seen previously in neocortical studies. And surprising to me was that the firing rate on a single unit level or single neuron level was one of the worst or relatively worst distinguisher between these 2 clusters. And there were fairly heterogeneous changes in both groups. And that would almost seem to corroborate the finding that other groups have put forth in favor of this network hypothesis. So to kind of disentangle this heterogeneous firing rate on a single unit level with the dual ictal territories that I'm seeing in PC space, I took a more detailed analysis of the single unit data by using template matching to track neurons through a seizure, and then further classify those neurons into putative inhibitory or putative excitatory cell types. Now, this data is still preliminary, which is to say that I don't have a great explanation for what exactly it's telling me yet. What I find is that, yes, there is heterogeneous firing on a single unit level in both clusters, but interestingly, putative inhibitory neurons and the cluster associated with seizing tissue significantly reduce their firing rate in comparison to the other cluster. And again, what this means yet is still kind of unclear to me. But in a parallel study being conducted in the lab, interneurons in neocortex, as depicted by these red hash marks here in the raster plot to your right and the red dots in the figure to the left for limbic structures, during neocortical seizures, inhibitory neurons do not seem to decrease their firing rate to the same degree that you would see almost a cessation of firing with inhibitory neurons during limbic seizures. And if anything, inhibitory neurons during seizures in the neocortex display evidence of tonic firing. So we think that this might hint at the possibility of distinct mechanisms underlying focal seizure spread between neocortex and limbic structures, where an active inhibitory process might be at play in limbic seizures. So in conclusion, the spatial consistencies of these arrays in feature space supports the view that focal seizures are limited to regions with well-defined patterns of neuronal activity, where one territory corresponds to seizing tissue since it's primarily identified by greater PLV values, as well as the epileptologist read of the epileptic genic zone. And further, I did not find any evidence for the network seizure mode with this study in particular. And going forward, I'm going to continue this more detailed approach to single unit analysis by looking at single neuron activity across the ictal transition and comparing that between neocortical and limbic structures, and using some recent techniques developed in the lab, further classify these inhibitory neurons into putative fast spiking interneurons or SOM interneurons, because if there is a mechanistic difference between focal seizure spread in neocortex versus limbic structures, I think this would have implications for surgical interventions for epilepsy, even beyond resection, such as looking down the road, the use of inhibitory neuron stem cell transplants. So I would like to thank my mentors, Dr. Guy McConn and Dr. Catherine Chavon, whose help and guidance has been, I really can't put a value on it. It's been very welcome, and they really got me through my research here. I would also like to thank the postdoc in the lab, Ed Merricks, who got me started with coding. I had zero experience before and really helped me get into the nitty gritty of signal analysis, as well as the rest of the collaborators in this lab. And then finally, the PNS Dean's Research Fellowship, which provided me with the funding support to take, a research year. Thanks.
All right, any questions for young young Alex? Any questions? Come on, where are epilepsy geniuses out there? The Ojemins, Hauptman, Coe.
Hey, yeah, I don't know if there's any geniuses here, but yeah, sorry, maybe you said this and I didn't catch this, but the recordings you're using for your phase locking, those were during seizures or
yes,
like okay, so they were all ictal recordings versus the HFOs. So with the HFOs, you didn't cluster based on signal during those.
No, so the HFOs was just to draw like an additional line of evidence for the original clustering, but for all the data that went into clustering included a 5-minute pre-onset baseline through ictal transition to up to a point of seizure pre-termination or secondary generalization for these focal seizures. And all seizures had electrographic onset before any clinical onset that were included in the study, at least.
And about for each, about how many epochs did you use? Was it just a single seizure, or was it?
Just so each patient, depending on the recordings that we had and whether or not I can get single unit data, at most we use 3 seizures per patient, but some patients only have 1 seizure represented in the data.
Sure. And then one last question is, did you do any sort of time frequency analysis at the same time? If you were
like spectrograms?
Yeah, or instantaneous frequency analysis, or just any measure of how any of that might have changed between pre-ictal and ictal.
So in terms of like the peak power of the dominant ictal rhythm, or just in terms of the phase of the low frequency potential?
Yeah, or the phase locking. Just did you see any something?
Changes?
Yeah.
Yeah, I think the phase locking value with the high gamma band. With the phase locking value, essentially what that is I used instantaneous phase of the dominant ictal rhythm and then correlated whenever there was a spike or activity to that specific phase of the low frequency rhythm. And so the PLV value incorporates sort of a time frequency analysis of the dominant ictal rhythm. And what I found was that PLV was like the better measure at determining whether or not you have entrainment to the dominant ictal rhythm. And that is our best distinguisher of whether or not you have actively seizing tissue versus not actively seizing tissue, which again has been demonstrated in previous neocortical studies, but I'm hoping to redemonstrate here as well in limbic structures.
Great.
Cool. Super interesting.
Thank you, Alex. Nice work. All right. Without further ado, Adam C. Glazer, who went to Middlebury, same place Dr. Kim went to undergraduate school, and then to Dartmouth Geisel School of Medicine now. He has contributed to 4 publications and has been active on a lot of volunteer activities. Do you want to tell us, Adam, something we don't know about you?
I'd say one fun fact about me is that I used to play professional soccer.
Professional soccer with what team?
I played in Australia.
Wow. Okay.
Yeah.
That's impressive. What position did you play?
I was a center forward, so score goals.
Well, fast and good. Wow, that's impressive. That is impressive. Okay. Without further ado, go ahead. Tell us.
So I'm sharing my screen. Does everyone see that?
Yep, we got it.
Okay. First off, thank you, Dr. Ellen Bogan, for the overly generous introduction. I've actually never been introduced before, so this certainly sets the bar high. While I have everyone in one place, thank you for an excellent month. I've both enjoyed myself and really gotten to know your group. So thank you for being so welcoming. Today I'm going to present some work that was recently accepted to Neurocritical Care and that I'll be presenting at the Neurocritical Care Society Annual Conference in early October. My paper is titled Seizure Prophylaxis Decreases Early Post-Traumatic Seizures and Death in the Elderly Patients. I thought this would be fitting given that this group is known for its neurocritical care work. I think Dr. Temkin is on this call, which only increases my anxiety, but is also an honor. And her paper is the basis for much of the guidelines that I'll be discussing. Shockingly, I do not have any financial disclosures to disclose. And so for background, the epidemiology of TBI has always been bimodal. There's been lots in children and lots in the elderly with MVC collisions scattered throughout. However, as the US population ages, the epidemiology of TBI is changing and the incidence of TBI in the elderly has doubled in the last 30 years. Some key issues in TBI are seizure management, post-traumatic seizures, and epilepsy. Early post-traumatic seizures are defined as within the first 7 days and occur in 11% of TBI patients, and post-traumatic epilepsy makes up 5% of all epilepsy. Current guidelines by the AAN and the BTF support AED prophylaxis for severe TBI, which is defined as GCS less than 8, for reducing early seizures. But notably, they're not currently endorsing AEDs for mild to moderate TBI and not for a mortality benefit or for late seizures. As I'm sure you're aware, the key clinical trial for these guidelines was performed by Dr. Nancy Temkin. This study was a randomized controlled trial of 404 patients with TBI that were randomized to prophylactic phenytoin or no prophylaxis, and she found that there was a significant decrease in seizures within the first week with prophylaxis, but no change in late seizures or mortality. However, the median age for this study is 34, and given that the epidemiology of TBI is changing, I decided to look at specifically whether or not this benefit of prophylaxis is consistent in the elderly population. So my study was a retrospective cohort study using the MIMIC database. The MIMIC database is a publicly available granular database of nearly 60,000 individual ICU admissions to Beth Israel over a 10-year period. And you can see how powerful this database is as it includes nearly full information for all the things listed on the slide. So using some self-taught coding skills, I was able to generate the cohort necessary for our study. So this is our figure 1 for our cohort creation. And I'm going to spend some time here as this, is essentially our entire methodology. So the first step was to select out only patients with relevant ICD diagnoses, so subdurals, epidurals, traumatic subarachnoid hemorrhages, skull fractures, concussions, contusions. And then we were only interested in patients above the age of 65. And then we also had to remove patients that received an AED, but not within the first 24 hours. Then due to imprecise drug administration timing in the database, in certain cases, it was not possible to determine if a patient seized and then got a drug or vice versa. And so in these select cases, those were removed. Then we also had to remove patients who had a seizure within the first 24 hours. And the reason for this is because both the control and the prophylaxis groups need a full opportunity for prophylaxis. The extreme example of this would be someone showing up to the ICU who is already seizing. This patient would enter the no prophylaxis group and would be marked as having a seizure. And so thus to include this group would actually predispose giving prophylaxis to having a benefit. We also had to remove patients who were undergoing a second admission for TBI and those who went CMO. And so that left 1,041 critical care admissions, 367 of whom did not receive prophylaxis and 674 that did. So our primary outcome was a compound measure, which was seizure or death within the first 7 days. We used a compound outcome because the idea was that dying should not be prophylaxis against seizures, to put it crudely. The downside is that most studies have looked at one or the other, so it makes it more difficult to compare to other literature that's out there. And then our secondary outcomes you can see here were the 30-day and 1-year mortality and ICU and hospital length of stay. So because this is not a randomized control trial, we needed to assess for significant differences between those receiving prophylaxis and those not receiving prophylaxis, and then use regression analyses to adjust for any differences that might exist between the two groups. So overall, patients that received AED prophylaxis were sicker. Those that received an AED were significantly older and also had more comorbidities and had a lower GCS. They were also associated with specific diagnoses such as subdurals and contusions, while those with traumatic subarachnoids or skull fractures were less likely. So I include this figure here, which is just really meant to be an overview of the events by group in our cohort. And so I didn't even include p-values, though I have them. I just wanted to give a sense of who our cohort is made up of. So you can see that the majority of our cohort was made up with patients with mild TBI, and that in our cohort, there was a total of 127 seizures and 169 deaths. As a proof of principle and just as a general self-check, you can see that patients that received AED prophylaxis in mild seizures, in mild TBI, sorry, were less likely to seize. That's obviously good news, because if that weren't the case, you should have trouble buying anything in this study. Figure 2 is kind of the meat of this paper and incorporates the regression analyses adjusting for differences between the groups. So in this first row, you can see unadjusted, so not adjusting for any differences between the groups. And you can see GCS broken down by mild, moderate, and severe, and then death at 1 week, seizure at 1 week, and then the compound outcome of death and seizure at 1 week. And the x-axis is an odds ratio. Model 1 adjusts for demographic differences. So you can see they adjusted for differences in gender, age, and ethnicity between the two groups. And then Model 2 also adjusts for all the differences that I mentioned on the previous slide. So differences in comorbidity and differences in GCS and specific diagnoses. And the last is an inverse weighting proportion, which is a statistical method that compares the most similar people in both the prophylaxis and the no prophylaxis group. So essentially trying to recreate an RCT out of this. And so you can see that overall odds ratios of foregoing prophylaxis increase the risk of death, seizure, or the compound outcome by between 2 to 4, and the results vary a little bit by mild, moderate, and severe, and the model that is used. And this is similar to other values in the literature. To me, the most important thing to look at here, and I know that there's a lot of data, is to look at model 2, because it accounts for the differences between the groups with regression, and it uses the compound variable, which I think is the most accurate one. And so if you just look at this data specifically, you can see that the odds ratios of foregoing prophylaxis are about 4, 3.2, and 3.9. And that's a foregoing prophylaxis. And you can see that it doesn't overlap with 1, meaning that these are significant values. One messy piece of data amongst many is that we did not find a significant impact on seizures just in severe TBI. That's obviously a big problem for our data, because that is actually the one pre-existing guideline. So that is an issue I'm aware of. Looking at mortality, you can see here in no prophylaxis in red and prophylaxis in green, and error bars in the shaded piece, and they begin to overlap at about 20 days, which is about when our mortality benefit stops. But there is a mortality benefit at 7 days. So summary and implications. So seizures are important in TBI, and the epidemiology of TBI is shifting towards the elderly. This fills a need to assess the role of prophylaxis in a more current TBI population. AED prophylaxis is associated with reduced early seizures and mortality across all levels of TBI, but is not associated with a longer-term mortality benefit. So the key finding here, and the distinction between current guidelines, is that we find a benefit in all levels of TBI severity and the impact on short-term mortality. Given this, it might suggest broadening guidelines of AED usage in this population. However, given that this does not seem to impact medium or long-term mortality, and we were not able to assess late seizure frequency, it's not clear that AED prophylaxis provides a clinically meaningful benefit. So I think where you land on whether or not to use AED prophylaxis is something of a judgment. Future work and areas of improvement. I think one thing that would really improve this study, and I would be working on, except that you guys have kept me so busy, is something like an illness severity score. So trying to identify kind of cases of polytrauma as a distinct subgroup from our cohort. One thing that had been bugging me is trying to think about why so many patients with mild TBI were in the ICU, and trying to identify kind of that pieces in that group. I started thinking about this because you might have noticed that our results are pretty similar across the models, whether or not we're adjusting for underlying differences. Initially, I was really excited about that because my fear going into the study was that the prophylaxis and the no prophylaxis groups would be so different that we wouldn't really be able to compare them. But now my new concern is that the models aren't adjusting for they're not adjusting for what they would need to be adjusting for. And so one thing I'm aware of is that identifying polytrauma cases might improve our ability to adjust. We don't have data available for late seizures. As people are discharged from the ICU, our database was not able to follow them. Late seizures are a key piece of information in this, and we are not able to assess for that. And I think the outstanding question here is, why does the mortality benefit not extend to 30 days and 1 year? And I think that calls into question whether or not there's a true neuroprotective effect of AED prophylaxis. So with that, I thank you, and I'll take any questions that you might have.
Thank you, Adam. Any questions for Adam?
Yeah, I have a question. This is Chestnut. Interesting study. We don't use AED prophylaxis here in non-penetrating injury because actually the BTF guidelines suggest it only for the decrease of seizures, not for outcomes, which again is based on Nancy's study. And so I just try to avoid the complications of treatment. This is interesting data. I think it is a problem that it's retrospective, in that it looked like when I was looking at your confidence intervals, most of the effect was actually in the influence of seizures on outcome and not the combined seizure there. It was actually in the middle column, and the right column looks very similar to that middle column, just seizure, which suggests to me that the morbidity is either caused by, which is a stretch, or associated with the seizure or the etiology of the seizure, which makes me wonder if the controls that you did statistically actually equalized the patients, because there was a choice in this group to treat or not, and it wasn't randomized. So this is kind of surprising data, I guess, and I'm just a little curious as to whether or not something didn't randomize, something wasn't controlled in your analysis that's actually associated with this difference. In other words, the seizure is an epiphenomenon and not the cause.
I think that's an excellent point. I agree that this data is both surprising and a little bit messy. Not specifically a response, but I think if you look at kind of the severe GCS group, it seems like prophylaxis is affecting death more in that group than in seizure, which I find really surprising. Another thing I find really surprising that I think is related to the point that you're making is that AED prophylaxis is affecting mortality in a mild TBI group. That doesn't really make intuitive sense to me. And I actually think speaks to the point that you make about, is there a difference in the way that these people are being treated, right? Because it doesn't, to me, that there's a mortality benefit in mild TBI with AED prophylaxis suggests actually more that there's something we're not capturing in the model than.
Exactly.
Yeah, no, I think it's an excellent point. And that's actually, that point specifically is why I started getting interested in ways of identifying polytrauma.
Yeah, I mean, maybe Randy, maybe it's the odds ratio, maybe it's the analysis that causes that. Nancy, I'm just curious for the analysis of the outcome versus the exposure. Is she on? Yes, not.
No,
I guess my comment would be that, it's an important group. The elderly patients are really an important group, and growing in size and impact. And this is an interesting finding, which you may say that RCTs on epilepsy have been beaten to death, but this is one that it hasn't. And this kind of thing could prompt a reasonable randomized trial to see if this is actually true, because that would change practice.
Yeah.
Yeah, no, I think
Nancy, why don't we hear Nancy? Is this the correct analysis using an odds ratio?
An odds ratio is a very reasonable analysis for a yes/no outcome. For the seizures, if you wanted to control for the death in a way without using a composite outcome, have you considered survival analysis? So looking at time to seizure using death as a censoring mechanism. So that if somebody died at day 3, you'd look at their seizure outcome up until day 3, but after that, they'd be out of the population. So that might be another option, but odds ratios are perfectly reasonable. It's very interesting results. Where are you in the publication process?
We've been accepted to neurocritical care, but we are writing up the revisions that they suggested.
Great. Congratulations on that.
Thank you.
If you want to look at another data set that may be helpful. It won't have the numbers as large as yours, but there's the TRACK TBI study run by Jeff Manley out of UCSF. And that has information prospectively collected.
Okay.
So you might be interested in doing that. Great study.
Yeah, I'd be eager to do more, but I've got to push this guy out before applications are in. So we can do that.
Well, you've got your priorities straight, but
Adam, I would say you meet Dr. Temkin before you exit.
Yeah, that'd be an honor. Thank you.
Door left. It'd be a treat. All right.
I think Dr. Ramirez wanted to make a comment. Is that right? We do have time.
Nino, are you on?
Yes, I find this also mechanistically interesting because, you know, AEDs means anti-epileptic, but they're actually reducing excitability. So maybe it prevents excitotoxicity in general, you know, and therefore it could, you know, prevent death. Yeah. Nothing to do with epilepsy, but with excitability, etc. in general.
Yeah, that gets I mentioned, I think in my last slide that this starts to think about the neuroprotective effects of AEDs. And I feel like that's a whole field of literature that I don't feel like I know very well, but I know it is out there and would be relevant.
Great. Nice job, Adam. Thank you very much so far. All right. Our last speaker, because his name begins with an O, Ayo Atun, who is, he went undergraduate to Indiana University, IU, and is now at WashU in St. Louis, well known to several of our faculty, great place, working with Dr. Limbrick at WashU and contributed to 8 publications. And Ayo, tell me something about you that wasn't on the CV. I didn't see your hobbies up here, but tell us. Just have to unmute yourself.
Thank you, Dr. Ellenbogen. So yeah, since I was little, I've always been interested in the arts and architecture and engineering. So I recently got involved in interior design. So I've watched maybe a few hundred hours of YouTube videos on interior design. And I now have my first client who is a classmate at WashU, and I will be interior designing our whole house. So
I'm impressed. I'm sure you're going to get calls from the faculty after this. So.
Yes, definitely. Let me know.
Okay, Ayo, go ahead. Thank you.
All right. Good morning, everyone. Thank you for this opportunity to present the work that I've been doing with Dr. Limbrick for about a year now. Today, I'm going to be talking about the cytopathologic changes in the choroid plexus and the CSF biochemical profile in intraventricular hemorrhage and post-hemorrhagic hydrocephalus. I have no disclosures. IVH, as we know, is a common precursor to PHH, as well as a common complication of prematurity. PHH as well as IVH carry substantial risk of neurologic morbidity, including neurodevelopmental delay, visual impairment, cerebral palsy, deafness, and many other morbidities. The pathophysiology of IVH and PHH is very well researched, but is not fully understood yet. So today I'm going to focus kind of on the inflammatory model of IVH and PHH. Again, there are many theories for the pathomechanism of IVH and IVH, PHH, and hydrocephalus. So if you think about the DAMPs and the PAMPs on inflammatory mediators activating receptors on the choroid plexus, leading to changes within the cell, whether it's on the transcriptional level, on changes in protein expression, leading to changes in either the tight junction proteins or channels on the choroid plexus itself, ultimately contributing to changes in the CSF and leading to hydrocephalus. So obviously this is this is a model, and not every part of this has been proven, but I'm going to discuss some part of this, namely the CSF biochemical profile and also changes to the tight junction. So the choroid plexus, as we know, is very important in hydrocephalus. It produces about 80% of CSF, and it's also immune cell gateway in the CNS. Studies have shown microglial proliferation in the choroid plexus in IVH and PHH, and studies from the Cali lab has also shown increased activity of certain channels, namely NKCC1 on the choroid plexus epithelium in IVH and PHH. Multiple labs have studied junctional changes in IVH and PHH, but a lot of them are focused on the ependyma as opposed to the choroid plexus. So my work, our work in the lab, has been to look at those tight junction changes on the choroid plexus epithelium. To do this, we focused on the ferret model. The ferret model was created in our lab by Dr. McAllister and the rest of the lab. The model was developed by injecting blood into the ventricles at about age 20 days, and some of these ferrets to go on to develop hydrocephalus. I'll discuss later how the ferrets that were blood treated who didn't develop ventriculomegaly actually still have cytopathology, which is one of the important findings of this work. Again, it's important to note that the ferret brain is, at birth, is similar to human brains at the beginning of the second trimester, so it makes it a very good model to study PHH and IVH, which are diseases of prematurity. Our hypothesis is IVH and PHH are associated with cytological changes, cytopathologic changes, immune cell recruitment, tight junction disruptions in the choroid plexus, and that may alter CSF biochemical profile, which may play a role in the development of ventriculomegaly in PHH. So I have tried to combine two major projects that I've worked on in the lab to sort of come up with this talk. So the first part is that initial changes in the cytopathology of the choroid plexus. So here are our specific aims: to demonstrate recruitment of inflammatory cells in the choroid plexus, to determine the changes in the choroid plexus tight junctions, and to determine changes to the CSF osmolality and electrolyte concentrations in the CSF. So for the first part, we had ferret kits that were injected with blood or PBS or intact. If they were PBS treated or intact, they were included as controls, while the ferrets that were blood treated but didn't develop ventriculomegaly were included as IVH, while the blood treated kits with ventriculomegaly were included as PHH. The reason why we included ferrets treated with blood without ventriculomegaly as IVH is because these ferrets also develop cytopathology such as ventricular zone disruption, which is when the ependyma loses N-cadherin expression, and there's astrogliosis, and this is a known finding in IVH and PHH. Ventriculomegaly was defined as ventricular volume greater than 2 standard deviations from the mean of the control group. And we performed immunohistochemistry staining, and that's what I'm going to show. So first, here are the groups. As I talked about earlier on, we induced this ferrets at about age 20. We performed MRIs at about age 40, and it was the MRIs we used to obtain the ventricular volumes using ITK SNAP, and then sacrificed the ferrets at age 60, at which point we collected CSF as well as did immunohistochemistry analysis. So first here is just to show ventricular volume in PHH, showing that there's increased ventricular volume in PHH. I mean, of note is also that this varies a little bit from the aim of the study, but of note is there is some edema in the IVH group compared to the control, but that edema is like periventricular white matter edema is resolved in the PHH group. This is something that the lab is working on, and I will just stop that there. All right, immune cells. So first we looked at astrocytes population in the choroid plexus. We do not see astrocyte proliferation in the choroid plexus. I can tell you from other work I have done in the lab that this is not the case when you cauterize the choroid plexus or yeah, so it's not the case when you cauterize the correct plexus or when you perform endoscopic third ventriculostomy. This is work that's still being done, just a more peek into some of the things that we do in the lab. Anyways, there's no astrocyte proliferation in PHH. IBA1 is a marker for calcium channels on cell membranes, and it's a good marker of microglia as well as macrophages. And as other studies have shown, we do see activation and increased proliferation of IBA1 cells in both the IVH group and the PHH group compared to control. Tight junction proteins in the correct plexus. On the correct plexus, there are only a number of tight junctions that have been named. One of them is Z01, which is obviously the intracellular adaptor, and Claudin 5, which is primarily in the correct plexus vasculature, as well as vasculature in the rest of the brain. Claudin 1 is on the correct plexus epithelium, while Claudin 11 as well is on the correct plexus epithelium. So here on the first panel here, you can see expression of Z01 on the epithelium as well as in the vessels. And what we found is that decreases in IVH and PHH, as shown here. Claudin 5 again also decreases in IVH and PHH. Claudin 1 as well decreases in IVH and PHH. So there seems to be a sort of general decrease in the expression of tight junction proteins. Claudin 11 we didn't find any changes in Claudin 11, and that's shown here. Of course, we looked at the basement membrane. To mark the basement membrane, we used collagen 4. And collagen 4, based on immunohistochemistry staining, we couldn't tell any differences. But again, these don't mean that there aren't changes to the structures of the collagen 4 and how they are organized and their function. So then the next thing we did was look at the CSF. Looking at the CSF, we saw there's increased CSF osmolality in IVH and PHH. Of note, this is the only time that PHH and the IVH group are actually different. So this obviously made us think about CSF osmolality as a driver of ventricular megaly, and lo and behold, it is correlated with the ventricular volume shown on the right. So just to dig a little bit more into the CSF osmolality and CSF biochemical profile, we're going to switch a little to human CSF work that we've looked at. So in a different study that I'm also working on, we looked at human CSF collected from different grades of IVH, high grade IVH defined as papule grade 3 and 4, which is essentially blood filling greater than 50% of the ventricles with or without parenchyma involvement, and low grade IVH as IVH grade 1 and 2, which is blood filling less than 50% of the ventricles essentially. And then PHH was defined as neonates born less than 34 weeks who weigh less than 1,500 grams, who have high grade IVH, FOR greater than 0.5, and have a greater than 3 day life expectancy. So switching gears a little and talking about the CSF. In terms of the CSF, multiple studies have looked at the CSF and proteins in the CSF, and obviously these proteins are inflammatory proteins that are elevated, cytokines, chemokines, as well as cell junction proteins. But only a handful of studies have looked at CSF osmolality or electrolyte in hydrocephalus, and none has evaluated these changes in IVH and PHH specifically. So we looked at that in human CSF. Here we included control infants that underwent LP for sepsis evaluation but had negative cultures. So here is the groups, and here you can see that the control and the PHH group were similar except for the FOR measurement, which would make sense. And however, one thing I wanted to point out here is that the high grade IVH group are younger, and they weighed less, and they had a higher CRIB2 minus T score. And CRIB2 minus T score is just a score for the general well-being of the infants. So looking at the CSF osmolality, again, here, looking at human CSF compared, in the past, what I've shown you in ferret CSF, we saw that there's increased CSF osmolality in the PHH group, but we didn't see increased CSF osmolality in any of the IVH groups. Total protein was elevated in both high-grade IVH and PHH, consistent with blood in the ventricles, which would probably lead to increased protein content. Glucose levels were reduced, which would be consistent with inflammatory diseases. And then looking at the electrolyte concentration, sodium, potassium, chloride were both elevated in PHH compared to the other groups. Calcium as well was elevated in PHH compared to control, and magnesium was also elevated. Looking at how these contribute to CSF osmolality, you would notice that sodium and chloride are the electrolytes that contribute most to changes in CSF osmolality. However, total protein didn't contribute as much to changes in CSF osmolality. So essentially what that's telling us that the CSF osmolality is changing not because there is blood. I should say not because there are proteins in the CSF, which we sort of assume is coming from the blood in the ventricles. But what's important is that total protein had the most change, essentially about 111% change. So just discuss this a little bit. Thinking about what would, panning back to the ferrets that I had initially shown, what would cause changes in tight junctions. It could be that these tight junctions are getting dissolved to recruit inflammatory cells in inflammation, and as shown here in the endothelia. In the endothelium, generally what happens when you recruiting neutrophils or immune cells, you have these disruptions and this breakage of the tight junctions. It could also be due to protease activity, and that's another work that we've been doing in the lab, which is looking at a particular endoprotease and its activity, and we've shown that the activity of this endoprotease is elevated in IVH and PHH, and it could be the activity of proteases. It could also be changes in transcription, as I showed earlier in the first figure, looking at activation of TLR4 leading to changes in gene expression. Now, implication of tight junction disruptions, one of it is what I've shown, which is it could change CSF content. There are certain efflux channels on the coriplex, on the blood CSF barrier that help with removing materials from the CSF. And if these barriers are disrupted, this could lead to increased CSF osmolality or lead to other changes that we've seen. The other thing is the tight junction is very important for the function of the coriplexus itself, in the sense that tight junction polarity, in an epithelium, polarity is very important, and we've seen that there's increased CSF activity in IVH and PHH, and this could be contributing to why we've seen increased CSF, because CSF osmolality, because we've also recorded increased CSF sodium potassium chloride, which would be consistent with the product of NK661. So these changes essentially might be related to each other. And then finally, I was just going to talk about glymphatics a little bit and the implication of this on the glymphatics. The glymphatics is another system that has been implicated in the pathophysiology of IVH and PHH. In terms of that, the glymphatics, the driving force for the glymphatics is generally the capillary pulsatility and aquaporin 4 expression. But if you imagine the CSF having a higher osmolality, even higher than the blood, then you can imagine that it would become a very important driving force for fluid movement between the CSF and the vascular space, and that could limit efflux, lymphatic efflux. And this is something that I'm also very interested in and we're looking at too. Just summary, first is to note that IVH and cytopathologic changes in the CSF and in the coriplexus exist not because of ventriculomegaly, but because of the presence of blood in the ventricles. And then second, PHH might differ from IVH in terms of ventriculomegaly due to CSF osmolality. And CSF osmolality changes are most likely driven by changes in CSF electrolyte concentration. And that is essentially the end of the presentation. At this point, I would like to thank everyone in the lab, Dr. Limbrick for his support and mentorship, and Dr. McAllister and the postdocs in the lab for all their help. Yep.
Great, thank you very much, Al. Any questions, Al? Anything? Nothing from our pediatrics.
Ao, hey Ao, it's Jay Houtman.
Yes.
Hi Ao, can you
Yes,
guys hear me?
Dr. Hoffman, yeah, yes, I can.
We can hear you well.
Ao, do you think these changes are going to be predictive of shunt-dependent hydrocephalus after PHH? And has anybody looked at these in a clinical cohort to see if there's, you know, a correlation with shunted out?
Yeah, so that's a good.
PHH?
That's a great question. That's nothing that we've thought about in the lab. I don't think anyone has looked at that. It's something we want to look at how do CSF osmolality changes as well as electrolyte concentration after shunting, and you know, pre and post shunt or pre and post ETV, pre and post corplex catheterization and things like that. So it's something we're interested in. I don't think anyone has looked at that.
Hey, Rich, it's Sam. I had a quick question too. Like,
One follow-up, sorry.
I was just going to ask, like, what do you think are therapeutic, you know, implications of the research? Because I know Dave's looking at, you know, potential drugs and various things that might mitigate some of these responses.
Yeah, one of them is you know, the protease activity, so ADAM10 is the protease that we've been looking at, and if that is involved in these tight junction disruption, then you know, drugs to inhibit the action of that protease could be one therapy. And the other therapy could be maybe not exactly therapy, but something to consider is that if the tight junctions are being disrupted and there is and you know, the blood CSF barrier is becoming loose, then that could be a route for drug delivery. Yeah, so those are the primary ones that we're sort of like thinking about at the moment.
Yeah, very nice. Any other questions? Thanks, Sam and Jason, for pitching in there. All right. Well, all three of you gentlemen did an outstanding job. We're very impressed, and we thank you for traveling all the way west for our rotation.